Welcome to the Brain Injury Association of Missouri Survivor and Family Education 2021. My name is Maureen Cunningham. I'm Executive Director with the Brain Injury Association of Missouri. Today's sessions are understanding types of doctors and specialists for care following brain injury and making and keeping relationships. Between the sessions, we will have a break. There will be time for you to refresh and stretch. There will also be information through a slideshow from our sponsors to learn more information about their services. Through sponsorships, this program is free of charge for you. The sponsors for the Survivor and Family Education are Missouri Department of Health and Senior Services, Missouri Agribility, the Missouri Beginning Farmers and Ranchers Program. Those are our program sponsors. Our keynote sponsor is The Whole Person. Our break sponsor is Ability KC, and education sponsors are Preferred Family Healthcare and Ozark Neuro Rehabilitation Center in Springfield. Let's please give our sponsors a round of applause. That means everybody, so we are waiting till everyone claps. Thank you. So I want to talk to you that if this is your first time on an online educational program, you are in listen only mode. If you have a question for a presenter during the session, at the bottom or side or maybe the top of your screen, there is a Q&A button. Click the Q&A button and type your question. I will monitor the questions throughout the session, and if time allows, at the end of the session, I will post the question to the speaker on your behalf. Reminder, if there is time, we will answer questions. So it is time to go ahead and get started with our first session of the day. Our Survivor and Family Education Program, our first session of the day is understanding the types of doctors and specialists for care following brain injury. This is a panel discussion, and the panelists are going to discuss doctors and specialists in the fields of medical care, rehabilitation, therapy, and mental health. Our panelists are Dr. Rusty Bond, a physical medicine and rehabilitation specialist with Cox Health in Springfield, Missouri. Susan Ford is a certified occupational therapy assistant with Ozark Neuro Rehab, also in Springfield. And our third panelist is Dr. Lindsay Vo, who is a neuropsychologist with Burrell Behavioral Center, also in Springfield. Please give our panelists a round of applause. Dr. Bond, would you please start our discussion?
Okay, thank you. Can you hear me? All right.
Yes, we can.
Okay. I'm here to talk about 4 different types of specialties that patients with brain injuries may need to see following their brain injury. And we're going to have 4 different groups. It'll be neurosurgery, neurologists, physical medicine and rehab, and functional neurologists, which is something I needed to check into myself a little bit, whether it's a relatively newer specialty. Next slide, please. Neurosurgeons, of course, after the emergency room, the brain injury patients will be seeing a neurosurgeon. That includes, for the more complex injuries, other than simple concussions, will include, skull fractures, brain contusions, hematomas, blood on the brain, deep hemorrhages. Many of these will be requiring surgery. Many will just need to be followed non-operatively or just monitored. Those might include intracranial hemorrhages, subdural hematomas, or epidurals. Another topic that they will follow is diffuse axonal injury, or DIA, or it's a shear injury. And what that is that with the patient, it's kind of like when you have oil and water in a bottle, and you have a quick acceleration, deceleration, rotation. The white matter and the gray matter will sometimes shear and twist, causing a brain injury. This may not always show up in the initial CAT scans, but later usually will show up in MRIs or on their cognitive exam. We anticipate that that was the type of injury they had. Once a person has reached the level of stability, they can be transitioned to an inpatient rehab program followed by rehab or neurology. Next slide, please. The neurosurgeon, as far as once they've been to the rehab unit, the long-term care may include a ventricular peritoneal shunt, and that's a tube that may go from the brain if there's too much fluid down into the abdomen. They may require bone flap replacement later if it was required at the beginning. Baclofen pump, which is a mechanical reservoir device with liquid baclofen that has a tube that will go into the spinal canal to help with severe spasticity, and the neurosurgeon will help with placement. There's also later treatment, sometimes not very often, but if there's a reoccurrence of a bleed or an aneurysm clipping may be required, then we may call on our neurosurgeon colleagues. Next slide. Neurology will also usually follow patients acute care, but also potentially in the inpatient rehab unit. But following after the patient leaves the hospital, both neurology and PM&R doctors may follow patients in outpatient brain injury programs, such as we're quite fortunate down here in Southwest Missouri. We have Ozark Neuro Rehab, which is a outpatient program with PT/OT, speech therapy, neuropsychology, may require case management as far as vocational rehab. Down here, we have Ozark Neuro Rehab, which is a joint effort between Mercy and Cox working together for post brain injury program. Neurologists may also follow for post-traumatic brain injury seizure management. Vagal nerve stimulators for those more serious anti-seizure control if regular oral medicines don't work. One thing was interesting, it's not necessary for brain injuries per se, but if a patient had Parkinson and brain injury, deep brain stimulators could be considered. Down here in Southwest Missouri, most of our neurologists are following the baclofen pump monitoring as far as medications. And then both PM&R and neurologists both do botulinum toxin injections for such as Botox or Xeomin, those terms you may hear, for injections for spasticity. And that's if a significant tightness in the arms, the botulinum toxin may be required. Next slide, please. Neurology also, besides the post-treatment, they may make referrals to driver's evaluations. Both rehab and neurology may both do that. And then also post-traumatic brain injury headaches or migraines. Unfortunately, many times patients with headaches or migraines after brain injury, these may be accentuated, and our neurology colleagues usually help with this type of care. And also traumatic brain injury medication management, which would be a whole lecture in itself, is of different types. Next slide, please. Physical medicine rehab, which I am, we have inpatient to rehab programs, but once there are patients with brain injury go to an outpatient program, it once again may include an outpatient program such as Ozark Neuro Rehab, which includes the PT, speech, psychology, and vocational and case management care. We may also be doing post-traumatic brain injury medication management, spasticity management, which include either oral medicines or Botox injections, such as Botox or Xeomin, as we discussed. Some PM&R doctors will follow baclofen pumps. We also sometimes provide life care plans. Many times that's medical legal type plans for long-term care. We always try to minimize medications if possible, with exercise as medicine is one of our key things we try to encourage, and also other home programs. Many times we may have to make referrals to other specialties, such as psychiatry. Unfortunately, patients with brain injuries, if they have pre-existing psychiatric issues, they may be accentuated after brain injury, and we may have to refer patients to psychiatry for depression or some other anxiety disorders, and our psychiatric colleagues may help with medical management. Ophthalmology, if there's some vision problems, may be required. Optometry, they may include vision therapy or possible prism type glasses. We may also refer patients back to neurology or neuropsychology, usually is long-term need, and also neurosurgery if there's any other acute medical issues that reoccur, as we mentioned before. Next slide. Now, functional neurology was actually something new that I didn't really know too much about. Dr. Ken Charlin in Ozark is a functional neurologist. He has a very nice website. He was very gracious to talk to me a little bit about his program. And functional neurology can be either an MD or DO neurologist. They may practice traditional neurology, but also functional neurology. Also was developed by chiropractic physicians who developed the board of American College of Functional Neurology. It's not under the traditional National Board of Medical Examiners, but they have a nice website you can go to. And they do have a statement in saying it defines as healthcare specialty focused on assessment, quantification, and rehabilitation of the human nervous system, utilizing sensory cognitive therapies and promote neuroplasticity, integrity, and functional optimization. This is an alternative approach to treating patients, and part of their goal is to look at common root causes or all causes as far as the disease and how it can be benefit from this functional neurology program. Next slide. This might incur imbalances such as hormonal, nutritional, sleep, movement, environmental factors, who you are, a whole body or holistic approach, fatty acid imbalances, mitochondrial imbalances, oxidative stress energy imbalances. And many of these programs will have a neurofitness program, including mental and psychological assistance. And once again, all causes of diagnosis. And in some of the, like I said, Dr. Charlin's website, they do discuss like brain injury tune-up type programs. So once again, that's more of a newer programs that I was not familiar with, but there's some good websites if you wish to go to those if you want more information. So those are the four categories of specialists that brain injury patients may see following their injuries. And I will turn it over to the next speakers. And thank you very much.
Hello, my name is Susan Ford, and I am an occupational therapy assistant. I work at Ozark Neuro Rehab. I would like to say welcome and thank you for having me. Today, I'm going to talk to you about 3 disciplines of therapy that you may encounter or have encountered, and just kind of explaining their role, in particular, how it relates to a brain injury rehab. So if you would do next slide, please. Thank you. I'll start with occupational therapy. For starters, occupational therapy is going to begin assessing a person's ability to perform self-care tasks. So that would be like grooming, dressing, bathing, toileting. That's kind of the first order of business, is to help people become as independent as they can with just the care of their own personal body. During this process, different types of equipment may be introduced by the therapist, maybe like a reacher or a certain type of shower seat, grab bars placed in certain locations. There's so many different things that could be used, but occupational therapists have a lot of tips and tricks and tools that they like to suggest for their patients. Next slide, please. So after having a traumatic brain injury, it's common to have some type of upper extremity impairment. That might be just like a weakness on one or both sides, really tight muscles, spasticity, and even just like incoordination, or it's called ataxia. But occupational therapists will be the ones to help with that as well. So joint mobilization, doing range of motion exercises, maybe using moist heat, different types of modalities. If you have like a paralyzed limb or partially paralyzed, we might use like an E-stim that provides just a little bit of electrical stimulation to elicit movement out of the muscle. So whether it's handwriting or self-feeding, anything to do with the upper extremity, occupational therapy, we're going to be the ones to help with that. Maybe using TheraBand exercises, TheraPutty to strengthen your hands. And also there's several different types of adaptive equipment also for this, maybe like a built-up handle if your grip strength is weak. There's a lot of different things that can be done to improve the upper extremity function. Next slide, please. Next slide, please. Thank you. So the next order of business would be the IADLs, or instrumental activities of daily living. This basically encompasses everything else that we do in life besides our own personal self-care. This is going to include like home care, cooking, cleaning, laundry, running errands, up to community mobility, managing your medications. So we will help a person that has been somehow affected by a brain injury begin to resume those activities, either through adaptations or different training or remediation. Just whatever we can do to progress a person towards independence in all of those areas. Driving is something also that we kind of pre-screen for here at our clinic. So that's usually at the very top of a person's list. They really want to return to driving. So we can begin to help someone understand if they're going to need to do a driver's evaluation to see if they're safe to return to driving. And if not, what could be done to maybe help them return to driving. We also work closely with vocational rehab. That is a service that's provided for people that have been sick or injured and are not able to return to their previous job, but they want to resume work. So we can help make those connections too. Next slide, please. Thank you. So along with those IADLs, or the everything else of life, there's a lot of cognitive function that goes into that. Just being able to plan and organize and have memory sufficient to perform all of these higher level activities. We also do cognitive activities that would challenge memory, attention, visual perception. We'll do different like simulated tasks. We can do medication management. We might do a cooking task with someone. There's several different types of visual perception activities that we do. So we also work on that cognitive function that's required for higher level activities. Next slide. And with regard to visual perception, that is also another area that's commonly affected after a traumatic brain injury. So visual perception has to do with how the brain is interpreting the information that the eyes are sending it. There can be several different things that go wrong there. And so in occupational therapy, we can work by introducing from like simple level puzzles to more complex level visual activities to help kind of retrain the brain to see accurately. Sometimes the ocular motor nerves are affected. And so that can lead to nystagmus, or maybe having a delayed eye or like a weak eye. So we will also introduce eye exercises to actually strengthen the muscles that move the eyes. Next slide. So we also focus on community reintegration. So advancing from personal self-care to care of the home and like your personal things to actually being able to get out into the community. So going to the grocery store, making a grocery list, having like the balance, strength, and endurance to get through the grocery store, managing your money. There's all these things that we can help a person with. Whatever their weakness is, will help to progress them so that they're able to do that as independently as possible. Next slide. So moving on to physical therapy. Physical therapists, like OT and speech, they work with strokes, traumatic brain injury, concussions, and more. You can find PTs in acute care settings, inpatient rehab, skilled nursing, outpatient clinics, and home health. Next slide. So physical therapy is going to focus on gross motor movements, and the goal is to just improve motor function, muscle tone, functional movements, improve a person's ability to transfer from supine to sit, sit to stand, ambulation. They'll work with maybe providing assistive devices from maybe a wheelchair to a walker to a quad cane to a single point cane. So PT just kind of leads the way in physical mobility and strength and balance for the lower extremities. Next slide. So the goals that are written for each patient are very patient specific as far as understanding the patient's prior level of function, what their goals are, what they physically need to be able to do to re-engage with life. So our goals are basically going to be the patient's goals. Physical therapy will also provide home exercise programs that can be performed in conjunction with coming to outpatient therapy and then also continued once they're discharged. Next slide. Okay, moving on to speech therapy. So speech therapy starts with just intelligibility, just helping a person articulate, speaking louder. It's very common, again, to have some type of speech impairment after a traumatic brain injury. So there's expressive language or expressive aphasia, where basically a person knows what they want to say, but they can't quite get it out. Speech therapy can help with that, help with word finding, and they work with people to just basically be able to synthesize and speak the words that they're intending to speak. Functional communication, they help with also providing maybe assistive technology and different types of alternative communication devices to help promote independence with communication. And then there's also receptive language understanding. So being able to understand what's being spoken to you. That is another skill that the brain has that can be affected by TBI. And so speech therapy will also help people with that. Maybe just having like being able to say yes, no, starting really simple like that, following like simple 1 or 2 step directions, and then progressing from there. Next slide. Speech also works with attention. So there's sustained attention, being able to just kind of keep your focus on one thing at a time, being able to filter out distractions from the environment, being able to do like a divided attention task, or we call multitasking. Memory, they'll work on like short-term working memory, and as well as longer-term memory. Next slide. So speech therapy will also work with reasoning. So deductive reasoning, problem solving, processing speed. A lot of times people that are affected with some type of brain injury, the brain is working, it's just, it takes longer. And so activities and exercises are performed in speech that will help kind of speed up the thinking process. They also help with the executive functions, planning, organization. Speech also works with swallowing. Sometimes if maybe they're aspirating or having some kind of difficulty, maybe pocketing food or something, they can make diet recommendations, provide different swallowing strategies, and then also just exercises to strengthen the muscles in the mouth to help create that bolus that's going to go down. And then they also work with just voice quality, the loudness of the voice, the strength of the voice. Sometimes, again, after a brain injury, a person's speech can just become maybe soft, maybe it's there, but it's just not projecting. So speech therapy are the ones to help with that. And next slide. Thank you very much.
Thank you very much. Dr. Vo, would you like to go next, please?
Hello, everyone. My name is Dr. Lindsay Vo, and like what was said before, I work at Burrell Behavioral Health in Springfield, Missouri, and I'm really glad to be here. All right, next slide, please. So I'll be going over 4 roles that, say, psychiatry, social work, psychology, and neuropsychology can play in your recovery or treatment. And these roles can certainly have a lot of overlap, and sometimes I find myself having a hard time drawing the line, but that's okay. I think that helps, I think, provide a lot of similar services when you may not have as much time or the resources to see so many different specialties unless you need to. So the first one I'd like to cover is psychiatry. Psychiatrists are physicians, so medically trained doctors who specialize in mental health disorders. You most often see psychiatrists prescribe medication to help alleviate symptoms, some symptoms such as depression, anxiety, sometimes sleep, a lot of different areas that really impact our daily functioning after something like a brain injury. Antidepressants are most often thought about when talking about psychiatry, but there are other things like anti-epileptic medications that help with headaches, anti-anxiety medications, and perhaps other secondary options that the medications can help with, such as sleep quality or just energy in general. As many of you may already know, after a brain injury, there's a lot of chemical, biological changes that can happen in our brain. And because of that, those things can really significantly impact our mood and our energy level, just fatigue, headaches, all of those symptoms that really cause our quality of life to be quite a bit lower. And psychiatrists can certainly be very helpful in coming up with a medication regimen, perhaps working with your neurologist or a neurosurgeon or other professionals that we have covered in this program to come up with the best treatment for you. And what usually happens is that they'll meet with you maybe once a week, once every other week or so at the beginning, just to see how the medications are doing and also how you are doing in general. Then there may or may not be adjustments made to your medications or your treatment plan based on the, results of the treatments. Next slide, please. All right, for social work can be a very broad area and field. What I think most often people think of when they think of a social worker is what they do for case management. So, and that is certainly one piece that can be covered by a social worker. But a social worker is generally a mental health professional with a bachelor's or master's in social work, and many of them are licensed to provide therapy as well. So my understanding of social work is that they take a very broad approach to helping the individual. So that might be perhaps today we'll work on those depression symptoms or the anxiety symptoms, but tomorrow perhaps I'll help you think about a way to apply for a job or to return to your job. Or is there perhaps some financial needs that you have, especially after an injury, depending on how you sustain that injury, it can cause a lot of stress in other areas of your life that then can cause secondary mental health stress. So social workers can certainly help with, I find them almost kind of like life coordinators, and they can help with the symptoms, but not only just the symptoms, but how can you access those services that would be really helpful, and perhaps can provide you more information about services you didn't know that the area had offered. Next slide, please. Clinical psychology. So psychologists are mental health professionals who are trained specifically in behavior and emotional disorders. They usually hold a doctor of philosophy or doctor of psychology. So they're not medically trained in the same way that psychiatrists are. However, the level of specialization in psychology and mental health, that's kind of their primary focus. A lot of psychologists are known to provide individual therapy, but also group and family therapy. And therapy is really just a broad term to, I guess, refer to a way to help the person or the group of people to achieve their goals, whatever those goals might be. So like Susan had stated before, for speech therapists, you might have some speech and cognitive goals. So in psychology, we might have mental health goals or general daily functioning goals that are related to how can I manage my stress better, or how can I learn to cope with the difficulties that I'm having now. And as you may know, as people who have been through this process of having sustained an injury, or maybe you're a family member who has seen all of these difficulties occur, psychologists can certainly help hone in on treating those symptoms of depression and anxiety, or other symptoms such as sleep disturbance, mood irritability, mood fluctuations. Perhaps there's a level of anxiety that's causing you to engage in behaviors that take up a lot of your time in your life, such as needing to wash your hands several times a day because you're experiencing so much anxiety. The brain is a very interesting organ, and psychology is just one field where we can try and help our brain recover. Next slide, please. Neuropsychology. So I'll probably spend a little bit more time on this slide since I'm a little bit more familiar with this field. But neuropsychologists are psychologists psychologists by training who have specialized in brain-behavior relationships. So not only are they trained in assessing and providing therapy to alleviate symptoms of mental health difficulties, but they also are trained to identify cognitive issues that might be related to an injury, so such as memory problems, having problems focusing, maintaining your attention, etc. So neuropsychologists can work in a lot of different capacities. So in one capacity, an outpatient setting, a neuropsychologist might provide evaluation services, meaning they may spend several hours with you, putting you through different tests and activities that kind of will place a benchmark as to where you're at in terms of how your attention's doing, or how your memory is doing, reasoning skills, etc. And then once those benchmarks are placed, part of the job too is to identify, are there accommodations we can focus on at work or at school or at home that might help compensate for those difficulties as you're recovering, or perhaps just tracking your progress in your recovery. If you sustained a moderate to severe injury, it can take several months to years to continue recovering. And for some folks, it's helpful to know kind of where someone's at to determine the level of treatment for them, such as speech therapy. How intensive can speech therapy be or might they need, or occupational therapy, for example, or physical therapy? Should they check in with their neurologist maybe sooner than 6 months for this reason? Or perhaps do they need a psychiatrist to kind of look at their medications and adjust something because they're experiencing some changes in their daily functioning? So a lot can come from an evaluation where we can identify the areas of strengths and areas for growth during your recovery, or how you're managing, that can help connect you to other services and other professionals that can help you. Another, I guess I'll talk a little bit more about what some of those other specialties might be that we might refer you to. So I've mentioned psychiatry and neurology and neurosurgery, but other places like chronic pain management, nutrition, sleep specialists, social work definitely, and of course I mentioned OT, speech therapy, and physical therapy. Sorry, OT meaning occupational therapy. I use so many abbreviations these days. And perhaps rehab neuropsychology, and that can be a different area as well, where they can help more specifically look at what are some ways we can practice these cognitive issues or cognitive strategies to help with that cognitive recovery. So can we focus on strategies to help you remember things better, or to help you organize better over time and come up with goals in that way? And it can be more treatment oriented rather than diagnostic. Okay. I believe that's all I have for neuropsychology, and that ends my portion. Thank you for having me again.
Thank you very much. So we do have a few questions that came in. So, if all of the speakers want to go ahead and unmute, so just like a panel, we'll speak up whenever you have some input. So one of the first questions, actually, I think is for Dr. Bond. What you mentioned a baclofen pump. What is that?
Well, the baclofen pump, the baclofen is a anti-spasticity medicines that what it works on the brain. The problem with the baclofen is orally, it's hard to get across the blood-brain barrier. So to get into the nervous system to help with spasticity, it's a medication that sometimes you have to go higher doses to get the spasticity effect. We always start very slow because it can make people very fatigued, and it's hard to get those doses high enough sometimes to get that spasticity. One real quick, if you're ever on baclofen and you get a higher dose, you never want to stop it quickly. You always have to go down on it slowly, otherwise you can get hallucinations and problems. Now, the baclofen pump is a liquid form of that medication, and they only have to use very, very small amounts of it in a liquid form. And the baclofen pump is a mechanical device with a reservoir where there's liquid baclofen in it, and the neurosurgeon will place that in there with a small tube into the spinal canal, and it has a very small drip of that baclofen into the central nervous system. So you're passing that barrier you can't get across with the oral medicine directly into the central spinal canal, and then that small drip of the baclofen, very small doses, will affect the nervous system and decrease the spasticity. So that works better because you have less side effects from the oral medicine of being fatigued and tired. And the small amounts work really wonderful. I have a lot of patients that, when they start out, they get super tight. We try oral medicines, they don't work as well. We may do Botox, but we get so high doses that we can't control their spasticity. So the baclofen pumps work really, really nice. And some of the newer studies show that it can really help with their gait and function and spasticity for all the muscles, not just the ones that might be injected by Botox. And even when I have patients who get baclofen pumps, many of them don't need the Botox or Xeomin injections anymore. And many times, if they do need a little bit, they usually only have to have a very small amount on maybe a few muscles that are really tight. So it's the technology, just like everything in technology, has gotten better all the time, and the newer pumps are better. And the neurologists usually monitor these down here. Some physiatrists will, the neurosurgeons put them in, but they can control the spasticity and make all kinds of fine tuning changes on that for even throughout the day.
Great. Thank you. Thank you. So the discussion on therapies within occupational therapy, physical therapy, and speech therapy, where does cognitive therapy fit in?
Excellent question. While I was speaking, I kept thinking about how much all of these overlap. And I would say, especially speech therapy, occupational therapy, and then neuropsychology as it relates to the cognitive functions. I think one way to kind of weed that out a little bit is like in occupational therapy, if we're working on something, it's like task specific. So let's say you need to manage your medication. Well, I can show different types of equipment that you can purchase to help you manage your medication. We can talk about using a calendar. We can work on different memory strategies. Whereas in speech, they are going to actually be working on the nuts and bolts of memory, of sequencing, like the actual brain function of like the skill of that. Does that make sense?
Mhm.
So, and then I believe then I'm not exactly familiar, and maybe Lindsay can speak to this, how neuropsychology, my understanding, at least with us, they kind of help more with coping and adjustment after and education for the family after a traumatic event has occurred. I'm not particularly sure that role in cognitive function. So Lindsay, do you want to speak to that?
Sure. And I think that's a great point, Susan, that there's a lot of overlap with how therapies can really help us cognitively. I think it kind of depends on the setting. So I do refer a lot of my patients to speech therapists who may help with the memory piece and the attention piece and focusing on those strategies. And it sometimes can be difficult, depending on where you're located, to find speech therapists that focus primarily on post-injury cognitive difficulties. And so I know there are some neuropsychologists who focus more on the treatment aspect and may provide similar kind of therapy services, whether that's weekly or biweekly for X amount of sessions to work on those different aspects. And so I guess that's a long answer of saying I think there can be some overlap, and hopefully it's more about access and where you can find it. Yeah.
Great, thank you. So we have, several more questions, and they all kind of relate, so I'm not sure which one to go first, so we'll go with which one came in first. So what is the difference between a neuropsychologist and a rehabilitation neuropsychologist?
Yes, that is a great question.
Is this more duplication?
And Susan, you may also have some information on this as well. My understanding is that rehab neuropsychologists are even more specialized in that there's the understanding of brain behavioral relationships and evaluation of where someone's at with their cognitive functioning, but also they're most often in a setting where they're working with other therapists, such as occupational therapists, speech therapists, physical therapists, neurologists, neurosurgeons, and trying to kind of help be part of that multidisciplinary team. And perhaps really soon after an injury, if they're at a rehab hospital setting, they may do a couple tests here and there, and they may say, okay, it looks like they're improving in this area, and in this area they may need some more support in. So how can we put our heads together as a team and think of, are these ways we can help this person improve in that area, if that makes sense.
Very much. Great. Thank you. So a lot of the specialists and the doctors that we've talked about today are soon after either the traumatic or the acquired brain injury. The question is, how can these services be long-term, and how can we persuade insurance to approve and pay for these services? Is that a whole nother session?
Well, the sad thing is, with my experience over the years with getting insurances to cover brain injuries, is a lot of different policies, unfortunately, will cut out a lot of the long-term cognitive brain injury kind of needs. What I see, when you look at your policies, on a big group, you need, sure, it'll take care of your heart attacks and fractures. But when it comes to long-term cognitive or brain injury needs, we see sometimes there's a deficit in those policies for those post long-term catastrophic problems. So it's good that when you do, obviously when big businesses look at that, because it may not occur very often in, let's say, in a company, but if they do have a patient with a brain injury patient and they look at the whole policy, the cost back to that company, a lot of times the insurances, patients will select insurances that don't have that catastrophic long-term need because of cost. So it is good that wherever you work, if not, hopefully this will never happen, but unfortunately we do see deficits in those. It is a fight and battle. I spend probably every Friday afternoon fighting to get things covered for patients. I know the Ozark Neuro Rehab and everybody, they're same thing. It takes a lot of hours to try to get coverage for patients for needs.
Lindsay, Susan, anything to add?
One thought that came to my mind were just the organizations like the Missouri Brain Injury Association and other, maybe I don't know if it's Department of Health and Human Services, but just the different agencies that can kind of collaborate together, whether it's vocational rehab, just agencies that have free resources and education, and just using those to help make those connections for longer term care. And I also am just thinking about just case management in general, having a contact or having basically kind of an advocate that can help you navigate what to do and where to go next. Yeah.
Great.
Mhm.
Thank
Yeah,
you.
we have outpatient social services help many times when we have people that don't have the resources. Our outpatient social worker, she's been a great help to get people linked up with different foundations to help with that. And we can get so much, obviously it's limited, but we try to spread it out in order to treat somebody for a longer duration than just very short duration, use up all their services quickly, because we know that it's going to be a long-term recovery. We really try to spread it out and so that we can continue to help them for a longer time.
Great, thank you. So we have another question. If you are working with a TBI survivor that is very interested in driving again and the family is concerned about the individual's ability, how would you proceed?
I can speak to this if you'd like me to. So I think the first step would be to go to the primary care physician and express that desire. If the family has concerns, then if there's a physician that's been following closely, they would probably maybe understand the family's concerns. If the physician could recommend a driver's evaluation, that would be it's like a 2-part screening process. At least that's how it is here, where they test you in the clinic to see, they check your visual reaction speeds, cognition, your physical abilities. They basically check to see, with all these standardized assessments, are you safe to get behind the wheel? And if they think, okay, you are, then they'll do an on the road assessment. And so that will determine that'll determine if they're safe or not to get back on the road. So sometimes it's not an all or nothing. Sometimes it could be like daytime driving only, short trips, depending on medication. Just, I mean, no, there can be different recommendations, but that would be my recommendation. And if anyone else knows anything more, please add to that.
Well, I order driving evaluations not unfrequently, and we've had good programs down here. We're very fortunate, and they've been very helpful. I always tell it to patients like a good housekeeping seal of approval. If you can pass through that, then it does get the comfort for the physicians to give that okay for driving. There's also insurance risks and things for the patients. Driving is considered to be a privilege, not a right per se. Physicians do have responsibility if somebody is definitely impaired and at risk. Families, of course, will sometimes take the car keys away until we can get it checked out. But really the best way is what Susan said, is the driving programs are very good. And even if somebody doesn't quite pass it, they're not quite ready for it, they can do some additional education and training to hopefully maybe them drive later or find out what other kind of adaptive issues that can be done. And once again, like she said, that sometimes driving in the local community during the daytime will work out for people. But the driving program is, there's some pretty well throughout the state, and any physician can order that.
That was actually going to be one of my follow-up questions, because I'm new to Missouri, was do you need a physician order for a driver's evaluation? Okay.
Well, thank you very much for all of our presenters. On behalf of the Brain Injury Association of Missouri, we will be sending each of you a gift. So please give all of our presenters a round of applause. Our next session is going to be making and keeping relationships. Dr. Lindsay Vo will be doing double duty and presenting that session at 11 o'clock. We now will take a short break, and so stretch, refresh, and be back here at 11. But in the meantime, on your screen, there will be a slideshow with information about our sponsors who keep this program free for you. So enjoy the slideshow, and we will see you back here at 11 o'clock.